examples of growing nevi that were in fact just nevi, very uniform type of lesions with relatively benign dermoscopic features. So again, what we're looking for is what's unusual for that patient. Something that just doesn't match their others, a spot that maybe they're focused on, and that's growing. And in those scenarios, you really do need to pay attention, because that's probably where the real early melanomas are. As they become non-uniform, they're becoming more and more advanced. So I want to kind of go over uniformity here a little bit. These would be lesions, if you look at the edges compared to the, all the way around, basically they're relatively uniform all the way around. These would be non-uniform lesions. You look at this edge here compared to this edge compared to this, compared to this, it would be non-uniform. These are just dysplastic nevi, these are melanomas. And I'll say that we don't fully understand what causes the non-uniform lesion features in dysplastic nevi. It could actually be the way they regress. They may not regress in a uniform manner. And I think as we get more and more information, we're going to get a better handle on what's causing those non-uniform features compared to the non-uniform features of melanoma. So how do we put this together? This is a lesion that's a little bit unusual for the patient. It's growing and changing. It's not particularly non-uniform yet. It's in situ melanoma. This is a lesion, it's really not entirely fair, but it had a little bit more red hue than the other lesions on the patient. That's something to pay attention to. If their moles all look fine, there's one that's a little more red than the other, a little bit more red hue, pay attention. Dermoscopically, not that super scary, but clearly growing and changing, a little unusual for the patient, an early melanoma. This one I did show earlier, lesion, a little bit dermoscopically off. When you go back, clearly changed in situ melanoma. This is that one that really a little bit more non-uniform features, clearly changed, and invasive melanoma. And then as they get bigger, they become more and more non-uniform, easier to detect. So let's kind of put this together as far as the universe of melanocytic neoplasias. There's 200,000 moles for every melanoma. Melanomas are actually quite rare. Your job is a little challenging to try to find the melanoma, but by kind of using a few of these techniques, you can do it. It's about 200,000 to 1. The melanomas are going to appear a little bit unusual. It's going to be more and more obvious that they're unusual as they develop. If you do have any way of identifying growth, the melanomas are going to continue to enlarge in size, and eventually they're going to become non-uniform. But some of your in situ melanomas here will not have developed non-uniform features. The development of non-uniform features is more and more worrisome for actually having invasive melanoma. In the clinic, we can do a pretty good job just looking at the patient using our eyes. Really, this is the best way to find the outliers, to find the ones that don't quite look like the others. Certainly having total body photos helps us a lot to discriminate what's changed or what's not changed. By using dermoscopy, we can look closer, we can see more of those features, we can see some of the non-uniformity or some of the structures that Natalia discussed earlier, which can help us to do a little better job of lowering our threshold to find the melanomas, but not remove the normal nevi. And then by using confocal microscopy, we can look even closer. This is just increasing our threshold, but honestly, just paying attention, you can do a lot of good work just really at the top there. Now, as far as approach, and Dr. Mazel had just gone over part of this, but really is important to think about how to biopsy these lesions. If you took this lesion, you look at this biopsy, if you look at this half, it would be read as nevus. If you look at this half, it's read as melanoma. If you're worried the lesion's melanoma, if you can't, really try to fully excise it. Taking partial samples really puts the patient and you at risk of potentially missing the diagnostic features. This is another case where a shape biopsy was taken, was read as a dysplastic nevus. Further punch biopsies were then done in this lesion, melanoma in situ. Here's a 0.34, and here it's a 2.2. So to the extent that you can actually do a full excision, that's an important thing to do. Clearly with larger lesions, it may be more challenging. You do your best to try to get the thickest part of the lesion, but you have to be aware that there really are some challenges with diagnosis for the pathologist if they're only looking at a portion of the lesion. For lesions where really less than 50% was removed, when they go back and look at the re-excision, many of them will go from an average of 0.66 to an average of about over 1 millimeter. So really about 21% end up being upstaged. So to the extent that you can get the whole thing off initially, try to get it off. Margins were reviewed earlier. This is kind of how we tend to think with in situ at 0.5 and the thicker tumors at 2 centimeters. But really what's important to realize that these are just guidelines, and that you need to pay attention to where the tumor is, where the location is, and what's the status of the patient. Clearly if there's evidence of metastatic disease, removing a very large margin is not going to make much of a difference. If there's a lot of potential disfigurement, you need to take that into consideration. Most of these studies show that margins less than 1 centimeter do have a slightly increased risk of recurrence at that location. But none of the studies show an increase in overall survival. If the cells have already left that area, they've left that area. So it's important to realize these are guidelines. To the extent that you can follow the guidelines, it's a good idea, but there's some flexibility that's important in patient care. It may not be appropriate to remove extra skin and result in a very disfiguring result, or something that may not improve the patient's overall survival. And certainly for these in situ tumors, particularly very large ones on the face, 0.5 is simply not enough, and 1 centimeter may not be enough. You may have to go wider than that. But it probably doesn't make any sense for an in situ tumor to be going clear to fascia. So be aware, these are guidelines to the extent that you can follow them, but there is flexibility, and you should, the patient needs to come first, and that these things can be changed depending on the patient information. So my focus really has been on kind of early detection, because I think that's where we make the biggest impact. Clearly the world is changing here, and we heard a lot about some of the issues with sentinel node. Certainly it is still a prognostic test that's being used, but it's good to see these new gene expression profiles coming along the way. And some of the recent data has implicated that maybe the gene expression profile may actually be a better prognostic test. So it's going to be interesting watching these things move forward on how this may change our care. There may still be a role for combining it with sentinel node. There may be a role for doing sentinel node to reduce future morbidity. If it's a high-risk tumor, you're expecting recurrence, you might end up damaging the facial nerve. It might make sense to go in there earlier than go in there later. But the world is changing right now in this area, so it's going to be interesting to watch. It's wonderful to have these new BRAF and MEK inhibitors, but it's been really very exciting to see what's been going on with the checkpoint inhibitors, the anti-CTLA-4s, and the anti-PD-1s. A lot of patients are still dying. We still have a lot of work to do. But as these therapies get better, we may very well get to the point where molecular diagnostics on your initial primary will say whether this is something that's going to be lethal or non-lethal. And if it's lethal, we may be able to choose some therapies that can start right at that point, and not necessarily doing sentinel nodes and some of these other approaches. So it's a very exciting, evolving time. So I think really though, I want to wrap up the series of lectures by really, part of our job is to identify those folks that are highest risk. I think everybody has a risk of having melanoma. It's important to pay attention. But when you're faced with a patient that's particularly high risk, you actually need to slow down just for a minute, look between those moles, look to see if there's something that's out of line. And it's not that hard to kind of do it globally. And I want to kind of wrap up with this idea. Look for the mole that's unusual, doesn't match their pattern, pay attention to it. Spot they're worried about, and it's not clear to you why they're worried about it. It's worth paying attention to. If this is a lesion that's also growing, you really do need to But just because it's growing doesn't mean it's bad. It's important to make sure that you're combining it the unusual and growing. Because again, 5% of acquired from E5 may be growing on an annual basis. Non-uniformity, the ABCs that we teach everybody, you know, they're very important and they're very good at identifying melanoma, but you don't need to wait till they're non-uniform. And you know, these are the things that you develop later. If you see them, I think it's an important way of identifying melanoma. It's actually a very useful teaching tool, but you don't have to wait to that point. It's actually a more advanced melanoma than the full ABCs have developed. But that I kind of like to wrap up. We do have multidisciplinary